Well, welcome everyone. Terrific that you've joined us here today. We have two fantastic speakers for you, and my name is Susan Law. I'm the Knowledge Mobilization Lead for Long COVID Web, and we have just a few introductory slides, and then we'll get going with the actual presentation. So thank you. Yep. We'll start with a land acknowledgement. We acknowledge that the land on which we live, work, and gather is the traditional, ancestral, and unceded territory of the Indigenous peoples who have stewarded these lands for millennia. Across this vast and diverse expanse, now known as Canada, we honour the First Nations, Métis, and Inuit communities who have lived in harmony with this land, water, and sky since time immemorial. We pay respects to our elders, past and present and emerging, and recognize their enduring connection to this land that sustains us all. As we engage in our activities, conversations, and shared experiences, let us remember the history, culture, and wisdom that shape the unique identity of each Indigenous nation. May we actively strive for reconciliation, understanding, and unity as we continue to learn from the Indigenous peoples and work towards a future of mutual respect, cooperation, and partnership. Just a short reminder of the purpose of these Long COVID webinars. First, to share evidence-based information, research results relevant for decision makers, researchers, clinicians, patients and families, and the general public. Secondly, to provide ongoing updates, spotlights on emerging evidence and scientific information about the activities of our national network. And thirdly, to contribute to reducing and managing misinformation about long COVID. We do have a code of conduct, and it's on our website at the link on the bottom of this page, which essentially says that we value very highly engagement around the science and its interpretation as well as its application. A commitment to reasoned discourse, as stated in our code of conduct, comes with a responsibility for all of us to ensure that any comments or questions remain within the spirit of positive, constructive, and respectful discussion. So we do welcome any and all questions and comments in this spirit. And just so you do know already that the cameras and mics are off, but we will pause for Q&A after each speaker. And please do post your questions in the Q&A. The chat is really for any purpose. People can chat amongst themselves, but I will be looking at the Q&A to draw the questions for our speakers. And we'll do our best just to capture all of them as we go along after each of the speakers. But thank you. We will post the link to our brief survey during the webinar. If you could take a few minutes just to give us some feedback on what we could be doing better or more of or differently, just let us know. Thanks very much. So I'll turn to our first of two speakers now. We have Dr. Tiffany Walker, who is an associate professor of general medicine at Grady Memorial Hospital at the Emory University School of Medicine, who's joining us from Atlanta. So thanks so much, Tiffany. I'll turn it over to you.
Excellent. Thank you so much. And thank you everybody for this opportunity to come and share some of the research that we're doing at our Atlanta Long COVID Collaborative. Let me know if you can't see slides or if you can't hear me, but I'll jump right in. So today we'll talk about patient perspectives on long COVID care delivery, comparing primary care versus our long COVID specialty clinics. And I have no disclosures of conflicts. So jumping into some background, I think you all are familiar that long COVID is underdiagnosed in clinical practice. Some of our earlier data from our site showed that less than 0.1% of our population had been diagnosed with an ICD-10 code U099 for post-COVID condition. This is in stark comparison to prevalence estimates that have really quite ranged, but using the CDC estimate of 7%, we can tell we're really far off from where we need to be. We have also seen in the literature that patients are experiencing fragmented care, provider skepticism or lack of knowledge of long COVID. Many patients are referred to multiple subspecialists with cost prohibitive workups without any clear answers or treatment plans. So we see this in the literature, but of course we know this ourselves because we're seeing it in real practice and our patients are telling us about it. We established long COVID clinics in our system in 2020 as we're seeing long-term sequelae of COVID. And we've really adapted and evolved over time. Our goal is to provide coordinated, patient-centered, multidisciplinary care. In 2023, the Agency of Healthcare Research and Quality, which is an agency out of the U.S. Health and Human Services Department, established a grant opportunity for long COVID clinics across the United States to create a long COVID care network and receive funding to establish long COVID centers of excellence. So we were one of those sites. And this just gives you a context of what we're doing in our clinic, what our aims are. This is what we proposed in our grant. So we aim to expand equitable long COVID care access through a person-centered care model that provides multidisciplinary and behavioral health services. And so in order to do this, to expand access, we've increased our clinic staff and hours. We provide telemedicine. Most of our follow-up visits are telemedicine visits and really helps for patients that are beyond our immediate geographic distribution. We are not yet doing e-consults, but we are looking into it, and many others in the ARC Long COVID network are already integrating this. A large proportion of our population in the Atlanta area have social determinants of health barriers, and so we have increased social services to help this population, provide resources to them. Of course, there's a very large population in long COVID that have disabilities, so having social services for those are very key. And for this population that have access to health barriers, they also have lower health literacy. They are less familiar with long COVID. Their providers are not diagnosing them with long COVID. So we're also doing community outreach so that we can increase awareness, increase community-based referrals and self-referrals. And then we have a campaign for provider education to increase identification, diagnosis of long COVID, referrals to our clinic, but also starting to build capacity at the primary care level for these providers to provide long COVID care there. In terms of person-centered care, we have care coordination services. We also have a patient advisory committee comprised of patients who receive care in each of our clinics, but also national and international patient advocates who have their finger on the pulse of what's happening in the long COVID community. We engage community organizations to hear their voices. And then as part of the grant, we conduct a patient-centered mixed methods programmatic evaluation, some of which I'll be speaking about today. And then we have in-clinic behavioral health services. We provide individual services as well as we've just launched group visits. So each of our patients have a touch with behavioral health and can be screened. If the patient is interested and has needs, they can be seen by a behavioral health specialist. We have increased subspecialty services offered, and we only work with subspecialties who recognize and validate long COVID, who have some knowledge in long COVID. And one of the ways that we do this is the last thing that we do is multidisciplinary case conferences. We're really excited about these. These are like tumor board style meetings where we get a number of subspecialists together on Zoom calls and we talk about complex cases in our clinic. This helps to expedite care for the patient, reduce and mitigate unnecessary referrals so they don't feel like they're constantly being shipped through the medical system. And also this gives us an opportunity to teach our subspecialists about long COVID. So it's a two-way education and we can increase capacity for long COVID care throughout the system. So what I'm talking about to you all about today is part of that mixed methods qualitative analysis. So we aim to characterize patients' experiences with long COVID care, both at the primary care setting as well as in our clinics. Examine barriers and facilitators to accessing and receiving care and the impact of care on patient outcomes. We conducted 6 virtual focus groups of 6 to 8 individuals per group receiving care in our clinics. We conducted these between December 2024 and April 2025. And we have two clinic locations. So I've kind of alluded to this. So Grady is our large urban safety net hospital. We provide care for medically underserved, largely a self-pay population, lower health literacy. And then our Emory population is tertiary care, high rate of insurance, usually a higher health literacy and access and resources. So different experiences between these two groups. We asked them about their long COVID care experiences, access to services, care coordination, health impacts. And then we conducted a thematic analysis using Max QDA and did consensus coding using a multidisciplinary team. We analyze our results in the context of the chronic care model, which is a framework for integrative chronic care management. So looking at this model, the top left, you see community. It's key to have resources, social supports, and policies that support the patient in their chronic care management journey. In terms of the health system, they need to provide evidence-based decision support to providers to keep them up to date on best practices. They need to design a health delivery system that is adaptable, is coordinated, and is patient-centered. And leverage clinical information systems like the electronic medical record and these large data sets to improve patient outcomes. And this all works together to create an informed, activated patient population that interacts with a prepared, proactive team with the goal of improving functional and clinical outcomes. So this is the context in which we're going to, the framework that we'll use to analyze our results. So starting first with community, and on each slide, you'll see some quotes from our patient population during the focus groups that relate to each component of the care model. So for community, some of the facilitators, our patients reported that social supports are key. There's no surprises here. Most patients had at least one person in their life that could help them physically, emotionally, help them get to appointments, help them organize data, and they felt like this was really important in their success in their healthcare journey. That being said, lack of long COVID knowledge is widespread and pervasive in the community. And so oftentimes the social support was limited to only one or a couple people or no one at all. So they really felt like they needed a broader network of support to be successful. They suggested to have a more coordinated public health effort to educate the community, which I totally agree with. Potentially screening, which I thought was a great idea, much like we do health screenings in the community for things like hypertension and diabetes. Better health policies, particularly as they pertain to disability resources. This, of course, is especially true in the United States. It can be quite challenging to get resources for disability. We have very high rates in our population. And then broad advertising of our long COVID clinics through community networks. So city council, local news, social media. They felt like we didn't have a strong presence and we were hard to find. So that was a critique of us. In terms of the health system, there weren't that many facilitators. There was a lot of frustration with the health system. One facilitator, as they mentioned, that primary care doctors of anyone were the most likely to try and advocate for them, try and validate them, but they still had a lot of negative provider experiences, even within primary care. So like we mentioned before, limited long COVID knowledge, dismissal or disbelief of symptoms, misattribution of long COVID to other conditions, particularly somatoform disorders or psychiatric illness, like as in this quote. They saw, again, multiple referrals without clear treatment plans. This caused financial and emotional burden. They felt that it was difficult to find specialty care, again, reiterating that they had to find us through personal research or networks and we could have more visibility. Their suggestions are to integrate long COVID care into standard clinical practice. This is something I feel very strongly about and agree with as well. I think this would take a fair amount of structural change. So I like to think about it in the context of diabetes, where the prevalence in the US is about 40 million compared to long COVID, which is about 20 million, so a 2-to-1 ratio. If we tried to provide care for diabetes only in select subspecialty clinics across our population, that would be really untenable. Same is true for long COVID. I don't think we can limit it only to long COVID clinics. We really need to decentralize and provide this care at the primary care level, but they have a lot of competing priorities and we need to make some structural changes at a high level to be able to support them in this. So I very much agree with the suggestion. We'll talk about ways we might be able to improve. One way to start is educational initiatives. So using traditional mechanisms within peer education. So continuing medical education, grand rounds, newsletters, informational handouts, scientific publications. And this should really be for all care team members, not just the doctors. Screening for long COVID in primary care clinics. Again, great idea. I've looked into this as well. Again, with there being a lot of metrics that primary care doctors have to meet and a lot of screening tools they already have to do, it's difficult to integrate that into a workflow, but I think this is something we should look into. Improving referral pathways, and then also personalized and adaptive treatment protocols that can be used by primary care. And this is something that our network is working on so they can be more familiar with some of the repurposed medications that we're using and better understand the care we're providing in our clinics. So moving to the activated patient, the main barrier here is that fragmented care, prolonged physical suffering, and unmanaged symptoms. There are really delays in care here. The facilitators oftentimes were just the patient pulling themselves up by their bootstraps, which is really unfortunate. They felt that they felt more informed and activated when they had self-initiated learning, building social networks, advocating for a diagnosis and treatment, really being organized, determined, and persistent when talking with care teams so they were taken seriously. I think that's highlighted well in this quote from one of our participants. I'm not really sure why I'm this weird middleman when I'm not a doctor. And unfortunately, I think that's a sentiment that's quite common in our patients. Suggestions here were to, for patients, were to build social networks and expand community by interacting with others that have long COVID. So you can hear others' experiences and feel more confident in your disease management. And then our clinics could host support groups to give participants opportunity to share their stories in a supportive setting. And we're starting to integrate that into our shared medical appointments. And then in terms of our team, as a prepared proactive team, facilitators were that the participants really, I think what they commented the most on was our care coordination, which they thought was successful. Once they were able to find us, they felt like we were very easy to access, and through the electronic medical record messaging, and we kept up with their needs. We provided accessible accommodations that were targeted to the individual needs of the patient. Because of this grant, we're able to provide longer visits. I'm not sure if that will be sustainable long term. I think it's very important, and I think that it's very necessary for long COVID care, but can be quite challenging at the primary care level. We provided validation, which was oftentimes the first time a patient had been validated, and oftentimes was a very emotional experience. They felt that we build trust through empathy, that we were quite knowledgeable of long COVID and kept up to date with the research. We were patient-centered, and it was a two-way street. It was a collaborative care, taking into account the expertise of the patient. Suggestions. So our barriers are integrated into suggestions. So as I mentioned before, it's difficult to provide the volume of care that we need to, considering how common long COVID is. So we have delays in appointment scheduling, and this is one of their concerns. They mentioned again improving clinic visibility. One suggestion I really liked was providing mobile services for those who have transportation challenges, much like our Grady population with access to care issues. But also for those who have physical limitations, those are bedbound, which is quite common in long COVID with high rates of disability. And I particularly like this because at our Grady site, our nurse practitioner that sees most of our patients, when she's not in the long COVID clinic, she works for our mobile integrated health system. And so we might be able to integrate these two. Provide more patient-centered education materials and resources. We have these, but I think we can expand upon them. And also, we've been given feedback for those with lower health literacy that we need to revise our documents. So we're going to go back to our patient advisory committee and get insights from them. And then outreach and advocacy to insurers, especially important in the United States, as some of this care is not covered by insurers and it impacts the sustainability of providing this care to our patients long term. In terms of outcomes, they felt that response to treatment was highly variable. Some have not seen improvements in our clinic. but still remain hopeful. Most report improvements in symptomatology, less functional limitations, improved mental health, and hope for continued progress. So in summary, like we had seen previously in the literature, long COVID, according to our patient population, is poorly understood by the general public and the medical community. This leads to alienation, care delays, it impacts quality of life, function, and long-term health. They felt that our long COVID clinics delivered largely on the key tenets of the chronic care model. We provided collaborative, coordinated care that inspired hope and improved clinical outcomes. Uh, Constructive solutions may increase public awareness and build capacity for long COVID care at the primary care setting. Again, I think we need some infrastructure to make that possible and sustainable. And then outreach efforts in that vein may facilitate integration of that chronic care model, the community, the healthcare system, to form an informed, activated patient population that can integrate well with the system. In terms of future research, we're going to take what we learned from this and we're going to go back to the primary care doctors and do interviews with them so we can understand barriers and facilitators to long COVID diagnosis and management, because I know there's many that are very invested and they have a lot of competing interests. So we want to find ways that we might be able to intervene or at least advocate on a national level. And then we also want to assess our community's knowledge, attitudes, and practices related to long COVID, particularly in the population that has lower health literacy, because we see that they're not getting referred by their doctor. They're not referring themselves because they don't know about long COVID. So we think there are a lot of people out in the community not receiving care, and we want to have targeted education campaigns for that population. And then just highlighting last our new initiatives. I talked about our shared medical appointments and behavioral health. We are also going to be launching pacing training because we find in primary care, in our clinic visits, we just don't have the time to dig down on triggers and coaching for the pacing in a dedicated way. And we think that's really foundational to post-exertional malaise. So we're going to do this where we can all learn from each other's experiences. Continuing awareness and education and campaigns, continuing to expand on them, and then again advocating for support, because one lunch and learn with primary care is not enough for them to have capacity to provide long COVID care, and they have other subspecialties that are trying to do the same thing, so they're inundated with people that want to talk about their subspecialty population. So we need to find ways to work with them and build infrastructure. And we've improved our visibility a number of ways through our system, but also by designing a website. You guys can visit us here. That's helped a lot with referral pathways. And these are my acknowledgments for our whole team, including our focus groups, our patient advisory committee, and our researchers and clinicians, as well as AHRQ for funding this project. And I'm happy to take any questions.
That's terrific. Thank you so much, Tiffany. Wow, that sounds like a really terrific program, and it's fabulous to see you working with primary care so closely. So that's really great. We do have a couple of questions from Lynn, so let's start with those. Anyone else has any questions, please pop them in the Q&A. So could you tell us a little more about how many patients have accessed the Long COVID Collaborative? How many are currently being followed? How many on the wait list, and what the current delay is between contact and getting a first appointment? So some metrics there.
Yeah, in terms of how many we are currently seeing, I think it's somewhere along the order between both sites of probably between 500 and 750, but I don't know that that's how many that we're seeing consistently across time. Some people come in, some people go out. We see patients, we call it the Atlanta Long COVID Collaborative, but honestly, our geographic distribution in the United States is quite large because of the issue with healthcare access for long COVID specialty care. So we're seeing patients throughout the Southeast region. I think something like 10 different states of people that are traveling to see us. Really challenging because in the United States, you cannot provide care across state lines at this time. So patients have to travel to see us. We can mitigate a lot of this with telemedicine visits if we're able to practice across state lines. So that's something we advocate for as well and are looking into some alternatives. And then what were the other questions?
Just how many of those are being followed, perhaps, are longer term patients? Maybe that's captured in your 5 to 750. But how many are on the wait list
Wait,
and
let's
the
see.
delay between contact and the appointment? Yeah.
Yeah, so we can get patients into our Grady facility quite quickly for that same reason I mentioned before. And it really bothers me and it really makes me nervous. I think there's an entire population that have long COVID that are suffering with it that are not getting to care because we see our Emory population overwhelmed with self-referrals. We do not see that in our Grady population. And I really want to target that population for increasing awareness. So our Grady population, usually you can get in within a month. Our Emory population for your first visit, so usually about a 4 month wait time, which is actually quite good compared to some others within the network. And we can usually see patients pretty consistently every 3 months or so. But Grady, we can see them at much faster clip because of that. And yeah, I've heard that from other sites within our network as well that serve a similar population to our Grady population that they're just not seeing as many self-referrals.
Okay. And perhaps just tagged onto that, just if you could just say again what the difference between the Emory and Grady clinics are.
Yeah, so Grady Memorial Hospital is a large urban safety net hospital in Atlanta. If you're familiar with any of the other healthcare systems in at least the United States, it would be a lot like the NYU hospital. We serve a medically unserved population. Our population demographically, I think. The vast majority are at or near the poverty level, primarily Black and Hispanic population, low rate of insurance, so access to care issues. They receive some subsidized care by the county, which helps get them into our clinic, which we are very excited about those resources. And then the Emory population is our large tertiary care center, largely an insured population, high health literacy. So they look it up, they figure it out, and they come to our clinic, and oftentimes already have suggestions for us because they've done the research.
Great. Okay, just a question I was curious about too is really around sort of sustainability and funding. So, what is the funding model to be able to run this clinic and pay for the various partners in the multidisciplinary care model? And I guess I'm also going to add on to that, just I know you said this was a grant. So, are there limitations with what's fundable within the grant versus what's going to possibly be sustained within the system itself?
Yeah, so this is a 5 year funding, 1 million per year at each site, and we are currently in year 3. It's allowed us to fund providers that would not be supported in our healthcare system by insurance reimbursement as it stands, and that's true of a lot of long COVID clinics that have shut down across the United States because of lack of resources. So it funds providers. We have advanced practice providers at both sites, Emory and Grady, that have greatly expanded our capacity to see patients. It provides social services support, care coordination support, support for our patient advisory committee, as well as our multidisciplinary committee. They get very small stipends to have these multidisciplinary conferences. Our patient advisory committee, same thing, receive compensation for this. It covers our community engagement and peer education campaigns and our evaluation plan. So that's what we can do currently. And then what we're aiming to do is have sustainability once the grant is over. I think that will be easier probably at our Emory site than our Grady site, but we're working on metrics of revenue so that we can make a case to our institutions to be able to sustain at some level. I don't think we'll be able to maintain all of these resources outside of the grant.
Okay, thanks. And just perhaps just quickly, if you could just make a comment on the extent to which there's sharing of resources within the long COVID network, rather than reinventing the wheel and duplicating. There's the Bateman Home Center, the World Physiotherapy, and Dr. Rick Arsenault here in Canada. So I just wonder how much of that is happening and what the limitations might be.
I think that's the direction everyone's kind of going in right now. I'm part of an expert panel from CMSS in the United States, which is a CDC-funded project trying to consolidate all of this information from the Canadian consensus guidelines to the AAP-MENAR guidelines to Bateman-Horn guidelines, because I think we've gotten to a critical mass where there actually is information out there and all these telementoring echoes, and there needs to be more consolidation of this information on all of these folks that are providing this. So we're working on getting a website together from our ARC network where we can consolidate what we're doing and what others have done. And I think CMSS is interested in that as well.
That's
That's the
great.
Council of Medical Specialties Services, and it's a CDC funded project.
Okay, perfect. Thank you.
Yeah.
There are a couple more questions, but I'm going to leave it there so that our next guest speaker can go ahead. But thank you very much, Dr. Walker. That was terrific. And you might be able to see in the chat and answer some of these questions that are there. If people, yeah, okay, I'll post them more publicly if I can. So that's terrific. Thank you. And we'll now move to Dr. Letícia Soares, and who is going to talk to us about her experiences and through a pre-recorded video. She is co-lead and researcher for the Patient-Led Research Collaborative. And as a person with lived experience, she suggested that she record her presentation, but she is present here, as you can see, to answer questions. So thank you very much for joining us and for doing the work to record this in advance. That's terrific.
Thanks so much for having me today. My name is Letícia Soares. I am one of the co-leads of the Patient-Led Research Collaborative, and I'm going to give a brief overview of the current advances in long COVID clinical trials. Before we get started, let me introduce the Patient-Led Research Collaborative. We are a group that was formed in April 2020, and within our group, we have people of very diverse backgrounds in data science, communications, public policy, social epidemiology, infectious diseases, neuroscience, and many other fields. And we integrate our professional expertise with our lived experiences of people who live with long COVID and other associated conditions in our research and the advocacy that we do. We published the first report on long COVID in May 2020, and since then we have authored and co-authored more than 40 papers in the field. We have created scorecards to evaluate patient engagement in research across several different illnesses. And we also funded $5 million in long COVID biomedical research, including studies on the pathophysiology of PAM, T-cell profiling, and the first clinical trial on monoclonal antibodies. So these are just some of the highlights of our work. Currently, we have been investing a lot in supporting long COVID clinical trials. And the way that we do this is first, so we provide feedback at every opportunity that we have. For example, we have been working alongside with reverse long COVID baricitinib trial, bezisterim trial with BioV, and we give Recover TLC trial design feedback every chance that we get. And we also work with trialists on recruitment. We write a lot about clinical trials, giving patient-centered directions to the field. And I'm going to be discussing some of our recent papers on this. And we also do some work in supporting clinical trial infrastructure with the PLRC registry. So the registry is a platform that is powered by My Data Helps, and it is IRB approved through Scripps. And it's a platform that is open to anyone with or without long COVID. Globally, you just have to be 18 or older. And the reason why we open this platform to anyone, including people without long COVID, is because we want a trialist to have the option to recruit from a pool of healthy controls and a pool of people with infection-associated chronic conditions from before the pandemic. We also track participants over time. So every 3 months, we send a very, very short survey asking people whether they had COVID in the past months, any new diagnosis, and ask them to fill out a functional capacity questionnaire. So if you're interested in partnering with us, please reach out to our team. And I invite everyone watching this presentation to join the registry today. So contextualizing some of the current clinical trial findings. So more recently, that we have been having several trials publish results. It's very clear that most long COVID clinical trials are not meeting their primary endpoints. So this graph that I'm showing here is the long COVID drug trials that have been completed and are listed, are registered in the clinicaltrials.gov registry. And you can see that most trials that have results available, they have not met their endpoints. They must be asking, how come, which one is this one trial here? And this is a sodium pyruvate trial that it was not placebo controlled. It only had 22 participants and it had only 14 days of duration. So it's a little difficult, to contextualize the relevance of this trial for long COVID in general. So we can say that the majority of the trials today that have results out, they have not matched their endpoints. And some of these trials, they were highly anticipated, among patients, because some of the patients have been having personal experiences with these drugs that were being trialed that had really helped with increasing their functional capacity and improving their symptoms more broadly. So it's unclear analyzing when we look at the design of these trials, if we can say that these results of not meeting the primary endpoint are very conclusive because there are design limitations in all of these trials. So we wrote a paper discussing some of these design limitations in collaboration with other long COVID patients. And some of the most common of these limitations are, first and very, very pervasive, is failure to account for post-exertional malaise. It's worth spending some time here discussing post-exertional malaise because it's a symptom that heavily impacts the quality of life. The functional capacity is highly impairing and disabling, and yet is very poorly understood and is rarely accounted for in clinical trials. So PAM is a prolonged exacerbation of symptoms or appearance of symptoms that is accompanied by worsening of functioning after an exertion, which can be physical or cognitive. And this exertion trigger was once tolerated before the illness onset. So this exacerbation of symptoms, it can happen like immediately after the trigger, but typically it has a delayed onset. So by hours and usually 24 to 72 hours after the trigger. So this symptom is also the cardinal symptom of myalgic encephalomyelitis, and at least 50% of people with long COVID have PEM. So symptoms that are exacerbated, they include fatigue, but they are not limited to fatigue. So you have a full range of symptoms that can vary from person to person and can vary from one PEM event to the other. And there can also be several different types of exertional: physical, cognitive, emotional, positional, meaning orthostatic challenge can trigger PEM, as well as sensory. So the severity and duration of the symptoms that appear or exacerbated is out of proportion to the type, intensity, frequency, and duration of exertion. With a prolonged, this is very important, it's prolonged and unpredictable time to return to baseline. That's why it is so, so, so important to prevent PEM. And this is not easily a stage that is not easily relieved by rest, and it may last days, weeks, or longer. So one PEM event may move a person from moderate to severe illness, for example. And research into PEM also shows that this is not really a symptom, is more like a pathophysiological state because it involves several pathophysiological changes in, for example, abnormal changes in gene expression, immune and oxidative stress markers increase, neurological function changes, and changes in muscle function in the microbiome, and there are many more other examples. So this means that PEM is a state that will affect outcome measures, and as such, it must be accounted for in trial design. But when we look at the design that is listed under clinicaltrial.gov, and this is for the trials that have been completed, only 3 out of the 38 trials listed measure or assess PEM in some capacity as acknowledged in trial design. Second design issue is centering on fatigue without phenotyping participants, and fatigue can stem from multiple mechanisms. So you can have fatigue that is part of PEM when someone has the ME/CFS phenotype. You can have fatigue as part of mast cell activation, as part of someone who have PEM and fibromyalgia phenotype, or as part of orthostatic intolerance, which is present in ME/CFS and phenotypes that have dysautonomia only. And this is an issue because when you centered on a single symptom, which can have multiple sources, you might fail to capture the subgroups in which the treatment may be effective. Second, this symptom-based measurement, especially fatigue-only symptom-based measurement, are generally inadequate for illnesses that have several deficits in functional capacity over time and across multiple dimensions. So this is very well depicted here in this graph that shows the episodic disability framework in the context of long COVID, in which each color line here represents a dimension of a disability in long COVID, which can vary over time and it can vary in response to contextual factors that can both improve and decrease the dysfunctional capacity. So when we have this unique single symptom-based measurement, we fail to depict all of these implications in functional capacity, which are much more meaningful to patients than just a few drops and a point scale of a generic symptom scale. And finally, a challenge that it's probably the biggest challenge that trialists face today are patient-reported outcome measures that don't have validity in the context of long COVID. And this can be because we don't know whether or not they have validity because the instrument has not been validated yet. And it can also be in cases of PEM in which we don't have a lot of options in terms of what can capture that pathophysiological state. And so, what are some recommendations to operate in this context of a highly heterogeneous, complex chronic condition uh, that doesn't have like a full array of patient-reported outcome measures or a single biomarker developed? So we collaborated with a few researchers in the field to write this paper in which we recommend some of these outcome measures that could be suitable in the context of long COVID clinical trials. Of course, that this will vary a lot. What will be suitable for one trial may not be suitable for the other, depending on the question that is being asked, on the hypothesis that is being tested. But looking at a very imperfect field, what is it that we can use today? What are the limitations of these outcome measures that we have today? And what is it that we have to do to move the field forward and improve these measurements so that we can have well-designed trials that have conclusive results? Um, and I'm showing this table here. It's just not for you to read, but these are all of the outcome measures that are out there available for long COVID clinical trials with this commentary on the rationale, limitation, and needs for the field. So I invite everyone to read this piece, which we hope it can be very useful for people designing these trials. And one of in the context of like not having specific patient-reported outcome measures that are validated for long COVID specifically, we highly recommend using a functional capacity instrument that has been validated in the context of MECFS, as the FUNCAP 55, or the shorter version, the FUNCAP 27. And it this takes into account these variations in functional capacity, taking into account that people can experience PEM. And what is also interesting about this is that it can, at least for MECFS, it can split patients into severity groups from very severe to mild disease. So this can be used in the context of long COVID clinical trials. We're suggesting, we're recommending the use, but it still needs to be validated for long COVID populations. But we believe that it has a lot of promise. It is an instrument that patients really easily relate with because of how it captures the condition. Um, so moving beyond outcome measures and talking a little bit about recommendations in terms of the design of the sample, something that we have observed a lot is a requirement, very strict requirements in the exclusion criteria of the trials, and that sometimes make the trial, not equitable, which is an example of the requirement of having the proof of a positive test, which excludes a lot of people first waivers when tests were not very accessible, people who have been sick more recently because testing is not routinely practiced anymore. So a lot of people may have had just a clinical diagnosis of COVID-19, but sometimes, depending on your trial, you really want to have that proof of a positive test. And one of the alternatives is designing a trial with a subgroup in which you don't have that requirement. So at least that you can enroll some people who didn't have access to testing for whatever reason. And another issue with exclusion criteria is people taking certain drugs, some people with certain conditions. So noticing the drugs that people with long COVID often are taking. So you might be eliminating most of your eligible population if you list some specific drugs and conditions there. So just be very mindful about this because it can make the recruitment process much harder than what it has to be, what is strictly necessary to be in the context of the design of that trial. Um, Second recommendation here in terms of simple design is design with an equity framework in mind, with representation of race and ethnicity, considering that people who are the most marginalized are the ones who have higher risk of developing long COVID. So make sure that your sample represents that in race, ethnicity, and gender, at least, including transgender people, and as well as age and illness severity. And I say illness severity because very severe patients tend to be excluded from a lot of trials because participation tends to be inaccessible to them. And when trial is completed, please disclose the findings of disaggregated data. It's very common that we see results out there that don't disclose disaggregated data or findings for these groups. So the third recommendation is to characterize common phenotypes and comorbidities that occur in long COVID. And sometimes you're going to have to design to capture sufficient numbers of these comorbidities depending on what your question or hypothesis is. But we recommend that these groups are fully characterized because there are very, very common among people with long COVID. And this means classified people with PEM, ME/CFS, POTS, MCAS, and Ehlers-Danlos syndrome and connective tissue disorders. This will enable you to make this subgroup analysis and to understand whether or not the drug may be effective for a specific subgroup of patients versus others. And in terms of designing according to disease features, uh, I spent some time talking about post-exertional malaise because it's very important for patients that this is taken into account. Both that PEM is a phenotype in itself that is characterized in the sample, that PEM events are tracked throughout the trial. So these events must be accounted for, they must be registered in some way, and make sure that the risk of PEM is assessed and is described in the consent form. And also remember what impacts symptoms, functional capacity, and disease severity, and account for that in the design. So some of these factors are the illness duration. Year one of disease may look very different than year four or year five, depending on the phenotype. Seasonal alterations in how the disease behaves, triggers of mast cell activation and PEM, menstruation, current medications, reinfections, and viral reactivations and other infections that the participant may be exposed to during the trial. And finally, accessibility. really make the trial accessible, plan to accommodate the needs of the most severe patients. Decentralized remote trials would be great for that. One example is the GLP-1 blocker trial from Scripps going on right now. And another very important way to prevent is to prevent iatrogenic harm from trial participation. And so we highly recommend this should be really, really a requirement for all teams working with people with long COVID to test regularly and to mask at all times. And also to be intentional in prevention of PEM due to trial participation. So patients should not be undergoing PEM just for being part of the trial. And just very briefly, some recommendations in terms of the drugs that we would like to see trialed. We would love to see high investment in drugs with curative potential. But we also want to see balance of this investment, ensuring that drugs that are currently being prescribed off-label for management of symptoms and some conditions, that they go through the clinical trial process to expand their accessibility. So there should be some balance in terms of effort and investment there. We would love to see a lot of investment in repurposed drugs, especially antivirals, monoclonal antibodies, immunomodulators, anticoagulants, microbiome modulators, and others. And I'm highlighting here CureID, which is an initiative to just collect patient experiences with drugs that are being prescribed off label for long COVID and inform clinical trials of repurposed drugs. We want to see innovation in trial design, new drugs, novel compounds, and also drug combinations, therapies that are targeting more than one mechanistic hypothesis, because currently all the completed trials that we have available are all single drug trials, and there are just two or three that combined drug with a supplement. And these were my recommendations. I just want to make a quick plug in to a resource that we have released very recently. Is the with Rhythm. It's the long COVID treatment guide. It's available online, and it's 30 lists 30 treatment options that are backed by data, patient expertise, and clinician expertise. So please check it out and help us disseminate this resource. Thank you so much for listening. And if you'd like to reach out and collaborate with us, please get in touch.
Thank you so much, Dr. Suarez, and I know you're here as well to answer any questions. But thank you so much. I'm curious to know just how you would say that your work and the work of the patient-led collaborative, what kind of impact do you think you've had to date in influencing researchers, policymakers? Like, where do you look for sort of instances of influence with your work?
I think we have been consistently a trusted source of information in the field because we are data driven, and we started by conducting our own research in long COVID. We still do our own research, but we sort of changed as the field changed and started supporting more research that is being done in the field. So we work a lot, like in collaboration with other researchers in the US and Canada, work a lot here in Brazil as well. So we are, trying to be where the needs are and where people, need us to be. And I think that the influence of this input of patient expertise that is based on data and that sort of pushes the field towards gathering data on stuff that we just don't know. For example, years ago, we published a review about reproductive health problems in long COVID. And at the time, there was very little data. The little data that we had available was ours that we collected in our first survey. And now I see several new papers being coming out like last year, this year, on reproductive health issues in long COVID. So that's the type of thing that we like to do, and the facts that we'd like to see in the field.
Oh, that's terrific. Yeah. And as one of our participants said, excellent recommendations for improving the quality and effectiveness of research. Thank you. So a question here, what do you think of first doing exploratory studies and to then identify a subgroup of patients that can benefit from an intervention before going on to do a larger study targeting that particular subgroup?
Yes, I think that's like sort of proof of concept studies are an excellent way to go. Like do like something that is small. There has been some really great studies coming out of immunology and like the autoimmune and immune modulator aspect of long COVID and sort of like very small sample size, but then informing, okay, like this is a mechanism that is relevant in at least like a subset of patients. This is how we tested, and this is how we can characterize patients. I think it's a good option to start with something and then move on into a bigger trial based on the results that you obtained.
Great, thank you. I will take this one last question and then we'll let people go because we're at time. But the comment and question is, I agree that we need properly done trials, but my huge caveat is that they need to have patients involved from the design period onwards. Too many trials that have not included patients are harmful and have set too high a limit on what counts as a positive effect. As a long COVID patient, being able to shower every other day instead of twice a week is a huge gain in health and well-being, but these small incremental improvements are rarely considered as enough to recommend a treatment, or perhaps to be considered as progress either. But do you have comments on that?
Yes, I think a well-designed trial, even trials that, don't meet their primary endpoints. The point is this study well designed enough so that this is conclusive, so that we can move the field forward? And we can learn things from these studies that can even inform clinical practice as well. So I think that we learn with negative results when the studies are well designed. So it's not, a goal to have like all trials meet their endpoints. It's a goal really like to make the field more efficient.
That's terrific. So I think we'll end the session here. Thank you, Nick, for posting the survey. It's just a very short feedback form. But I just want to say to our two guests, thank you so much. That was both terrific presentations and very, very helpful to our audience and to those who will listen later. We do post these online, and I know that lots of people do have a look afterwards. So thank you and take care, everyone, and join us next month. Thank you.